Assalamu alaikum and welcome to the BYOS Academia. I am Dr. Ashfaque Rahman Khan. Will be conducting today's academic session on a very important topic, that is the basic uh, and the interpretation of the Sac Patency test. It is a basic topic for all young ophthalmologists. To make this monotonous topic more interesting, I had put some important clinical aspects and the fun facts that will help to go through this slide easily. Before jumping into the Sac patency test, we need to go through the lacrimal apparatus anatomy, the function of the lacrimal gland, tear pathway, vascular supply, and nerve supply of the lacrimal gland. Then comes the Sac patency test and its interpretation. So lacrimal apparatus anatomy. Lacrimal apparatus anatomy, it basically consists of two portions, uh, which is the secretory part that helps into the tear formation. It is 90% done by the lacrimal gland and 10% by the accessory lacrimal glands. And the drainage part that includes the puncta, common canaliculi, common canaliculi, rectimal sac, nasolacrimal duct. So first we gonna go through the lacrimal gland. It is a J-shaped serous gland. Lacrimal gland is situated into the lacrimal fossa, which is also almond shaped, superior temporal aspect of the orbit. It has two parts, the orbital part and the palpebral part. Orbital part is upper large and the lower smaller part is the palpebral part. Both these parts are separated by the levator palpebral superioris muscle, and the palpebral part is 1/3 of the orbital part and situated in the lateral part of the upper eyelid. So when we evert the upper eyelid, we can see the palpebral part of the lacrimal gland. Now here is a clinical aspect point that uh, I like to share. When a patient came to us with dystopia, mainly the displacement of the eye intromedially, then we all have to focus on the growth or enlargement of the lacrimal gland, because it's the anatomical position of the lacrimal gland that produces the enlargement of it, that produces this displacement. Now, accessory lacrimal glands, as we know, it contributes 10% of the basal tear secretion. These glands are the glands of Cruz, Wolfring, and rudimentary lacrimal gland. After the lacrimal gland, then comes the ducts of the lacrimal gland, which opens into the lateral part of the superior fornix into the conjunctival sac, and they are 12 in number. And in the orbital part there is 4 to 5, and in the palpebral part it is 6 to 8 in number. The fun fact is about 1 milliliter tear secreted per day from each duct, and half of it evaporates and rest half drains. And then comes these tear, when it is formed and with the help of the lacrimal ducts, it comes into the conjunctival sac. Then comes the drainage system. The drainage system of the lacrimal apparatus, it includes the puncta, then canaliculi, common canaliculi, lacrimal sac, nasolacrimal duct, which ultimately opens into the inferior nasal meatus. Now comes the puncta. It is located at the posterior edge of the lid margin, at the junction of the lash-bearing lateral fifth six, which is known as the pars ciliaris, and the medial non-ciliated 1/6, which is known as the pars lacrimalis. Normally, they face slightly posteriorly and can be inspected by everting medial aspect of the lids. The upper puncta is 6 mm from the inner canthus. Lower puncta is lateral to the upper puncta. Now here comes when any hampers happens in this drainage system, like in case of the punctal stenosis, in case of the punctal displacement due to ectropion, due to punctal blockage with the lash, and in case of the punctal displacement due to large carbuncle, there will be watering of the eye, which is known as epiphora. Now comes the second part, which is the canaliculus. It has a vertical part which is 2 mm and the horizontal part which is 8 mm, both joints at ampulla, and it is slightly dilated. The thickness of this canaliculus is only 0.5 millimeter. Common canaliculus, it follows the 90 and 10 rules. Well, what is 90 rule? Mostly the 90% unites the upper and lower canaliculi and forms the common canaliculi. A small diverticulum of the sac is known as the lacrimal sac of Meyer. Its opening is about 2.5 millimeter below the apex of the lacrimal sac, but the rest 10% of each canaliculus opens separately into the sac. So here is another clinical fact. The angle between the canaliculus and the common canaliculus is 57 to 65 degrees. The common canaliculus to the lacrimal sac is 58 to 90 degrees. So when this angle increase between the common canaliculus and the lacrimal sac, then there is increased susceptibility of the dacrocystitis. Now comes the lacrimal sac. It has three parts: the fundus, body, and the neck. It is 10 to 12 millimeter long. The fundus is 3 to 5 millimeter, and the body is 10 to 12 millimeter. The nasolacrimal duct, inferior continuation of the lacrimal sac, it opens into the inferior nasal meatus by downwards, backwards, and laterally. It is 18 millimeter in diameter, 18 millimeter long, and 3 millimeter in diameter. The parts of the nasolacrimal ducts are the intraosseous part, which is 12.5 millimeter, and the intrameatal part, which is 5.5 millimeter. The important measurements that includes the vertical part of the canaliculi, which is 2 millimeter, horizontal part is 8 millimeter. Then it forms the common canaliculi, and fundus is 3 to 5 millimeter, body is 10 millimeter. Both of these joining forms lacrimal sac. The nasolacrimal duct, it is the longest, which has two parts. The interosseous part is 12.5 millimeter and the intrameatal part is 5.5 millimeter. The functions of the lacrimal fluid, we will not elaborate it. Mostly the function of the lacrimal fluid is lubrication and protection. Then it gives the optical clarity, supplies the nutrient and oxygen, debris removal, antimicrobial defense, which helps. Lacrimal fluid contains antimicrobial agents like lysozyme, lactoferrins, and immunoglobulins, which helps to protect the eye from infections. And it also helps in fluid balance and hydration. The pathway of the lacrimal tears. As we already know, the lacrimal gland and the accessory lacrimal glands produces the tear. Then via the lacrimal duct, it's open into the superior conjunctival fornix. And from there, with the help of the blinking, this tear passes to the lacus lacrimalis. And with the help of the puncta and upper and lower puncta common canaliculi, they drain into the lacrimal sac. And from the lacrimal sac, from to the nasolacrimal duct, and it opens into the nose via the inferior nasal meatus. Now here is another clinical facts that I like to share. In our regular practice, we find that the susceptible patients of the chronic dacrocystitis or DCR operation are the uh, females. Why females are more prone to this infection? Because the size of the nasolacrimal duct is smaller in females and it blocked earlier. The females are more predisposed to nasolacrimal duct obstruction than the male. The blood supply of the lacrimal gland, it is mainly the arterial supply done by the lacrimal artery branch of the ophthalmic artery, the venous supply by the lacrimal vein, which drains into the superior ophthalmic vein and eventually drains into the cavernous sinus. The lymph nodes that involves are preauricular and submandibular lymph nodes. The nerve supply, the sensory innervation by the lacrimal nerve, a branch of the ophthalmic nerve. Then the nerve supply of the autonomic innervation, which consists of the parasympathetic, which has the preganglionic fiber that originate in the superior salivatory nucleus. Then with the facial nerve forms the greater pectoral nerve, then the nerve of the pterygoid canal. These fibers synapse in the pterygopalatine ganglion and postganglionic fiber travel with the zygomatic nerve to reach the lacrimal gland. The sympathetic portion, they have the preganglionic fibers originate in the superior cervical ganglion and the joining the greater pectoral nerve and forming the nerve of the pterygoid canal. Sympathetic fibers travel with the parasympathetic fibers to reach the lacrimal gland. Now here comes the type of sac patency test. Mostly in our outpatient department, we do the regurgitation on the pressure over the lacrimal sac, which is the Rho plus test. The gold standard is the lacrimal syringing on or irrigation test. There is other test, that is FDDT, which is fluorescent dye disappearance test, and the advanced test are the dacroscintigraphy or dacrocystography. So what is Rho plus? Regurgitation on pressure over the lacrimal sac. When we found a chronic dacrocystitis patient, there is a swelling in the lacrimal sac area. We have to apply gentle pressure over the lacrimal sac. If there is fluid regurgitation from the puncta, it is positive for Rho plus, which indicates the nasolacrimal duct obstruction of the patient. But in case of the negative test, it suggests a patent or open drainage system. In case of the fluorescent dye disappearance test, the procedure it is carried out with the 2% fluorescent. It is instilled into the conjunctival sac, and the observation, we observe the eye dye clearance of that eye for after 5 minutes. The interpretation, in case of the normal, it is minimal dye remaining, delayed clearance, partial or complete obstruction. In case of the advanced imaging, there are dacroscintigraphy, there is physiological assessment of tear drainage, and dacrocystography, which is the radiological contrast imaging for the detailed anatomy. So what is sac patency test? It is a procedure in which the sterile saline is pushed into the nasolacrimal apparatus starting from the puncta to test the patency of the tear drainage pathway. So we are going to have different segments of the sac patency test and its interpretation. First, we have to go through the punctal dilatation, lacrimal probing, lacrimal syringing, hard stop versus the soft stop, interpretation of the sac patency test. So what is the indication of the sac patency test when we conduct this test? Any blockage in the rectimal drainage system, if we suspect, to rule out that blockage, we have to do the SPT. In case of the identify of the site of the blockage, we have to do the sac patency test. Also, in as a preoperative assessment before any intraocular surgery like glaucoma surgery, retina surgery, and most common important cataract surgery, which is phaco, that might lead to secondary infection, we have to assess this test whether there is any blockage of the nasolacrimal duct or not. Now, lacrimal dilatation, it is a process of dilating the puncta. What is the indication? Used to dilate the puncta in small puncta before syringing. In case of the punctal stenosis, we do the lacrimal dilatation, and canalicular repair with Monoca stent, we also do this lacrimal dilatation. What instrument that used for this punctal dilatation? Two instruments, that is needle shape punctal dilator and Castroviejo lacrimal dilator used in this punctal dilatation. And the insertion of the dilator, it should be in step 1, vertical incision. We first of all, we have to sterilize the punctum dilator with mediswab or iodine, then insert the dilator vertically downwards for 2 millimeter and gently rotating clockwise and anti-clockwise. And in step 2, we have to pull the lower lead temporally to straighten the ampulla, so that there will be a straight line formation between the vertical and the horizontal canaliculi. To rotate the dilator horizontally and insert the dilator. And horizontal insertion, it is again shown, we have to pull the lower lid temporally to straighten the ampulla. Pull the lid temporally to straighten the ampulla will help in dilating our puncta. Now comes the lacrimal probing. The process of passing a thin metal instrument probe into the lacrimal sac down to the duct to diagnose, if possible, opening of the blockage is known as the lacrimal probing. The lacrimal probe that we use are the Bowman's lacrimal probes. When we have a Bowman's lacrimal probe, there are it available in various size, like in 4 zeros, 3 zeros, 00. It has 0.1, 0.2, and 0.3. What are the number indicates? It indicates the size of the probe and which is appropriate for age of the patient. Like in case of the 4 zeros, the size of the probe is 0.7 millimeters. So it is helpful for the 3 months age patient. This chart indicates the size of the probe along with the age of the patient and the number of the probe, the relation between all these three. The lacrimal probing. Lacrimal probing, when we do the lacrimal probing, we have to go through the similar steps. Like first you have to introduce through the puncta, pull the eyelid, lower lid temporally so that the line of the horizontal and vertical canaliculi straighten up. Then we push the probe. What we will find two stop, which is hard stop and the soft stop. When we find the hard stop, when we push the probe through the puncta over the lacrimal sac, and if we feel we have a hard stop, that indicates we have reached the margin of the sac, and after the margin of the sac there is lacrimal bone of the lacrimal fossa, so the pathway is clear. But in case of the soft stop, when we encounter the probe is not going through the uh, at the end of the limit of the lacrimal bone, and the stopping filling is soft, that indicates there is any blockage in the common canaliculi. There might be any diverticulum or the blockage of the common canaliculi, so the probe cannot pass over the lacrimal sac up to the nasolacrimal bones. The diagnostic probing indications to diagnosis the upper lacrimal system blockage and canalicular obstruction. If there is a proximal blockage, the distance from the puncta while we probe will not be exceeding the 3 millimeter mark. So it will be less than 3 millimeter. But in case of the mid level, there is 3 to 8 millimeter, and distal obstruction, it is more than 8 millimeter. So when after we probe, if it is more than 8 millimeter, then we will assure ourselves, and the result will be there is distal obstruction of the nasolacrimal duct. So in case of the sac patency test, it can be carried out in operation theater, mostly in a sterilized environment. Sometimes in our minor operating theater, we do this procedure. Before we start, we have to wash our hands, position of the patient comfortably with the head supported is a very important thing. Ensure the good lightening. Always explain, we have to explain the patient what are we going to do. In this procedure of the sac patency test, we need the normal saline, a sterile 1 millimeter syringe. Maximum time we use 3 or 5 millimeter distilled water or normal saline for this test, but I prefer to do with 1 millimeter syringe, because when we push the uh, saline through the puncta, it may uh, hamper the lacrimal pathway with the force of generating by the 3 millimeter, 3 milliliter or 5 milliliter or even 10 milliliter syringe. But in case of the 1 milliliter syringe, the force is lesser, and it will not disrupt any pathway of the common canaliculi or canaliculi. A sterile needle ship dilator, a sterile lacrimal cannula, local anesthetic eye drop, clear cotton wool or gauze swab, a towel. First, we have to use the tile to avoid the spillage, and then check the needle shape dilator. Do not use if there is any damage to the tip. You with the syringe, draw up 1 ml of saline, then attach to the cannula. We have to install the lower local anesthetic eye drops and wait about 30 seconds, and then ask the patient to look upwards and outwards away from the nose, so that we can prevent any injury that might done in case of doing the procedure to the cornea or conjunctiva. With the cotton wool or gauze swab, gently pull down the lower eyelid, expose the lower puncta. Inject the fluid slowly. Ask if the patient experiences any salt taste at the back of the throat. If no, there is a blockage in the nasolacrimal apparatus. So the result could be yes or no. If the patient tastes the saline in the throat, there is no obstruction and the lacrimal apparatus is fine. It's negative for SPT test. But if there is no water reached through the throat or nose of the patient, there is a obstruction at the nasolacrimal drainage apparatus. Here is a procedure of video that I am showing. First, I have to gently insert the dilator, then also pulling the lower lid outwards and through the lower puncta. In case of the upper puncta, we have to always ask the patient to look outwards so that we cannot injure the cornea and conjunctiva. And again, the same anti-clockwise and clockwise movement of the dilator, and also straightening the vertical and horizontal canaliculi. And this method we have to repeat 1 or 2 times before going into the syringing part. And after doing the dilatation of the lower puncta, and we have to do the SPT sac patency test with the 1 milliliter syringe, and we have to wash the fluid through the lower puncta. Here in this patient, the fluid comes out from the same opposite puncta. So there is a blockage of the nasolacrimal duct, and we have to carry the same procedure with the upper puncta also. And in this method, again the fluid comes out, so the test results are positive for nasolacrimal duct obstruction. Now we have to measure whether there is a hard stop or soft stop, because it is important before surgery to evaluate the patient's common canaliculi block, or it is the distal blockage of the nasolacrimal duct system. So this dilator probing is also carried out through the lower puncta first, straighten up the lower lid, then pushing we feel the hard stop, and we have to measure it whether how long this probe enter into the lower puncta. So for this procedure, we hold the margin. We can measure by taking a mark with the sign pen and the surgical marker basically. And this surgical marker, we will measure into the next slide. We measured this diameter of the blockage, which is hard stop, after near about it, the slide caliper shows about 12 millimeters. So it is more than 8 millimeter. It is a hard stop, so there is a distal end of the nasolacrimal duct obstruction. In case of this video, it is also done in a case that I have recently operated. It is a failed DCR. So in case of the failed DCR, it is very much important that we have to know the interpretation, because in failed DCR, if there is hard stop or soft stop, along accordingly we have to manage the plan. This is another way we can measure the hard stop or soft stop with the punctal probing. And in this case, the patient also had a fistula over there, over the sac area. Then we mark the, firstly we mark the probe, then we enter the probe and feel the stoppage is hard or soft. And with the marking on the probe, we can easily measure up that there is a soft feeling in the lower puncta, and in the upper puncta there is hard feeling. So there, in this case of the failed DCR, there might be remnant of the lacrimal sac, and also the bony part that regrows sometimes, or inadequate osteotome has been made in these cases. Now comes the advanced interpretation, combining syringing and the type of regurgitate and probing the result. In situation 1, when 100% regurgitation of the fluid through the same puncta and the fluid is clear, then in probing, upon probing, we will find soft stop on proximal obstruction. Not, the probe will not go past the 8 millimeter barrier, which is the distal obstruction part. Then the blockage is common canalicular block. In situation 2, 100% regurgitation of the fluid through the opposite puncta, it might be common canalicular block or the nasolacrimal duct obstruction. In situation 2, when we found the mucoid regurgitate and on probing we will find the hard stop, there is complete nasolacrimal duct obstruction. But in case of the clear fluid and the hard stop, the complete nasolacrimal duct obstruction with fibrous sac. The distal end of the sac is fibrous. That's why the fluid that we found from the upper other puncta is clear fluid. But in case of this type of situation, when there is clear regurgitate and on probing we found the soft stop, that is common canalicular block. In situation 3, less than 100% partial regurgitation of fluid through the opposite puncta and patient response yes to test sensation, it most likely common canalicular stenosis or partial nasolacrimal duct obstruction. In these cases, there are three scenario. Again, the mucoid regurgitate when we have the mucoid pass like regurgitate, and on probing we will find hard stop, then there is partial nasolacrimal duct obstruction. And when we find the clear regurgitate and a hard stop, there is also partial nasolacrimal duct obstruction with fibrous sac. But in case of the clear regurgitate with probing in probing resulting soft stop, then the result is common canalicular stenosis. In situation 4, fluid freely injectable but no sensation feel in the throat. There might be an internal fistula, and on painful probing, this might lead to false passage. Sometimes while doing the probing, if we push the probe too much with the forcefully, then there might be a chance of false passage. Now situation 5, the freely patent pathway, syringing positive, probing is also normal. There is no anatomical problem. The problem is functional or physiological. So in a nutshell, a lacrimal syringing positive, anatomically patent lacrimal system. It's not a physiological test and gives no information about the functional blockage. And the contraindication of the sac patency test are in case of the any acute dacrocystitis, lacrimal abscess, acute conjunctivitis, and chronic dacrolithiasis, we should not perform this test. Thank you all for your patience hearing.